7:39 now. In our Better Bodies report, 1/5 of all strokes in this country happen to people whose hearts don't beat right. Their condition is called atrial fibrillation. Treating people who have it is easier now than ever before. Just ask this West Side man.
Hi, I'm Gerald Burns, and I had AFib, and they put me in the hospital, told me to take 3 deep breaths. I went to sleep, and it's fixed.
Actually, it wasn't quite that simple. Like nearly 3 million other Americans, Gerald Burns has AFib, or atrial fibrillation. It makes his heart beat wildly.
I was watching television, had my hand over my ear, and I heard my heart skipping beats. I said, that's probably not right.
Burns lived for years on medicine to control his wild heartbeat and protect him from AFib's most dangerous side effect.
When the heart's not flushing its blood out properly, that can develop blood clots. And that's a common cause of stroke. So atrial fibrillation is known to cause, we think, about 25% of strokes in older patients.
Making new treatments like this one at St. Vincents Atrial Fibrillation Institute potentially life-saving. For some patients, surgical options are recommended. For Gerald, it's a catheter ablation.
Okay, ablate here.
After creating a 3D map of Gerald's heart, doctors find the sources of electrical impulses that cause his AFib and ablate, or burn the tissue, forcing the impulses back on a normal path through the heart, with a simple goal: cure AFib once and for all.
We already know that Mr. Burns has benefited tremendously from his procedure. His change in his life is really nothing less than transformational.
Months after his catheter ablation, Gerald Burns has had no atrial fibrillation and hopes to be off all medicines soon. With his doctors okay, he's back on the road.
I'm riding a bike, I'm back to work, I don't have any chest pains, I got a lot of energy, and I'm looking for it to even get better because I'm starting to ride more like I used to ride. Real nice.
Good for you. So with us to talk more about AFib is Dr. Mark Mostovich. He is a cardiac surgeon, and Dr. Samal Oza, who is a cardiologist. Good morning to the two of you.
Good morning.
So there are 3 ways to treat AFib. That's what it's called, right? Yeah. Sure. There's three ways: medicine, catheter type ablation, and surgery. Normally you two compete for patients, but you've come together for this special mission. Tell me what it is, Dr. Mostovich.
Well, any clinician or patient who has atrial fib knows that it's a very stubborn and frustrating rhythm to deal with. So by combining medical, catheter-based, and surgical technologies and techniques, I think we can offer the best possible cure rate for atrial fib.
Dr. Oza, let me ask you about this new type of ablation. It's through a catheter, which means what? It goes in through your leg?
It goes in through the femoral vein, which are both veins in your legs. We put catheters up to the right side of the heart, cross over to the left side of the heart, and actually get rid of the atrial fibrillation where it originates from.
And what kind of downtime is there for the patient?
Well, generally we admit a patient the morning of the procedure, do the procedure, and they'll stay overnight, and probably about 90% of our patients go home the next day.
Now, Dr. Mostovich, you specialize in that and also the surgical option.
Correct. Just a bit of a historical perspective. The Cox-Maze procedure, which is what we're talking about, is a surgical curative procedure developed by Jimmy Cox. He was a Duke graduate in the 80s. And through the years, we've tried to take that procedure, which is done in a very maximally invasive way, open heart surgery, and make it minimally invasive by duplicating these so-called lines of ablation, which in the surgical model were basically cuts that you sewed up and they created scars, which are barriers to electrical activity. Well, we're taking that and using technology like radiofrequency or focused ultrasound to do it in a closed chest or catheter-based approach.
So, Dr. Oza, when do you know if a patient is better suited for catheter, surgery, or medicine? How do you figure that out?
Well, it's a complicated question. It has to do with the other comorbidities that a patient may have.
By comorbidities, you mean what?
By other diseases of the heart. If they have problems of the valves, problems of the arteries that surround the heart, they may be a better surgical candidate. Otherwise, we have to decide whether or not catheter versus surgery is okay for them, just based on patient preference, as well as the other sort of downtime issues that you have after the procedure.
All right, Dr. Mostovich, people who are listening this morning who may have felt their heart skip a beat a time or two. I know you can't diagnose anybody, obviously, but what would you tell them would you recommend they go see a doctor? What other symptoms might they have?
Well, oftentimes people have a feeling of a heart skipping, as you say. Most of the time it's a benign thing, but if they do have this recurring, they should see, you know, their local doctor first and get into the system, and then they can see someone like Dr. Osa, an electrophysiologist. You know, there are therapeutic options now with people with AFib. In the past, typically what we did is kind of just assigned them to a life of a blood thinner and something to control their heart rate, and not really dealt with atrial fibrillation. Now we're targeting the actual rhythm disturbance, and we want to put the patient back in a normal sinus rhythm. It means a lot in terms of how they feel and the protection from stroke.
And as we saw with that gentleman there, he can get back to his ways and actually bike again. So that's good news. Dr. Mostovich and Dr. Osa, thank you for joining us this morning.
You.
And if you'd like to talk to somebody about atrial fibrillation, you can contact the Institute at 904-308-AFIB. That's AFIB.